All right, let's do it. What's up, everyone?
Hi, Abby.
What's this look like? Well, what's this part look like?
Some sort of neoplasm of fat cells.
Yeah, there's a neoplasm. And there's
Maybe a
fat.
lipoma.
So, okay, some kind of
Hmm.
lipoma. A little more than just lipoma. Now, all of this.
Yeah, that's more.
It looks like as though that there's vessels
Oh, there are vessels. We all have to live somehow.
and it's spindly.
It is spindly.
Is it a spindle cell lipoma?
It is a spindle cell lipoma. What else does it have that spindle cell lipomas have?
Are those fibroblasts?
It
No.
does have fibroblasts. It has the
Okay.
ropey collagen.
Be collagen.
That ropey, and so sometimes it looks like shredded carrots. You know? It's actually remarkable how often it has that. Both spindle cell lipomas and pleomorphic lipomas, you could find that.
Mhm.
What about this one?
This looks more blue. Um,
Yeah, there's
maybe the
blue. I agree. So there's a bit of a myxoid stroma.
is just like a mixed-white well, it wouldn't be a mixed-white tumor. Um,
More ropey collagen.
More ropey collagen.
Is this a
yeah.
pleomorphic?
Is it pleomorphic though?
Is it a pleomorphic No, something mucinous, and it's also a lipoma.
Also
Oh,
spindle cell lipoma. So
Oh,
oh,
spindle cell
interesting.
lipomas can have any amount of those components. They can have your fat component as the lipoma component, your spindle cells, your myxoid part. So you don't have to have a lot of fat. There is some fat in here, by the way, but you really don't have to have a lot of it. Some call them, just like you can have skim milk. You have your fat poor or fat free spindle cell lipomas. But yes, the rope you picked up on the ropey collagen. Ropey collagen is a good giveaway in the cases where you're not picking up on the fat. What about this?
This is a tumor. There's also fat here.
There's fat.
It's also spindly.
It's also spindly.
Is this another
Well,
lipoma?
what's different?
There's
So what else is here?
some blood vessels.
There's pronounced vessels here.
Yeah.
What's the differentiation of these cells?
Poorly differentiated.
Oh, it's pretty well differentiated. I can tell what cell type it is.
I'm guessing it's angiomyolipoma, but it doesn't look like angiomyolipoma. So I feel like there's some like epithelial.
Why does it not look like angiomyolipoma?
Uh, there's some cells doesn't look like fibroblast.
Um,
I don't know.
well, what do you expect to see in angiomyolipoma?
So you should see a mixture of fat tissue plus
Okay,
vessel
wait.
plus
Let's go one at a time. Fat tissue. Do we have it?
I
Yeah.
think it's
Okay, what
fat.
else do we want to see?
Vessels
Vessel.
and muscle.
Vessels. Do we have it?
Yeah.
Yes,
What else do we want to see?
Muscle.
like a
Muscle. All of these cells with with these with these glycogen snacked vacuoles, particularly around the vessel that contracts the muscular part of the vessel, by the way.
Avi, quick question. So the muscle component refers to like smooth muscle, right?
Yeah,
Okay.
not skeletal muscle. Okay, do we have it?
Yeah, I guess I'm trying to like differentiate the skeletal versus smooth muscle by looking at the like a shape of nuclei, I guess. Or
Well, the skeletal muscle you'll have this look skeletal muscle looks nothing like this. You'll have striations. And the nuclei are going to be out to the side of the muscle, to the muscle fibers. Okay, so we have all of our components for an angiomyolipoma.
Angiomyolipoma.
That's what it is. This is an angiomyolipoma. Um, what is this associated with?
Is that with it could be like tuberous sclerosis, or is
Tubular
it
sclerosis. If it's okay, if it's in the
kidney?
kidney, good. Renal angiomyolipomas are associated with tuberous sclerosis. What about cutaneous angiomyolipomas?
Is it? I don't think it's Reed, like
That
Reed
was what I
syndrome.
was thinking, Reed syndrome. That's the only thing that could come to mind.
If you are
Yeah.
of the camp that thinks that all cutaneous angiomyolipomas are just angiolyomas or some kind of leiomyomas potentially, but really it's just leiomyomas that you need to associate with Reed syndrome. So the answer is no, it's not associated with tuberous sclerosis. Cutaneous angiomyolipomas are not thought to be associated with tuberous sclerosis. What about this one?
Um, Kind of like similar appearing, but less fat. More
Less fat or no
muscle,
fat?
no fat.
No fat.
Vessel.
Yeah, vessels, muscle differentiation.
Yes.
Yes. Okay.
Angiolymyoma.
Angiolymyoma, you can see that the muscle it's like some would say that the muscle that was forming the muscle component forming this vessel wall just is the tumor. It just keeps going. You're looking for the outer layer of the vessel, and it's just, oh, it's all the way over here. So angiomyoma, yes, angiolymyoma. All right. What do we have?
Fat. Looks spindly again.
Okay, so spindly. What else?
Oh,
Pleomorphism.
yeah.
Pleomorphism, yes.
Leiomyosarcoma
Okay, so that's on so
or
different. Okay, one thing on
lipo.
differential leiomyosarcoma.
Uh,
Well, we have to rule that out.
Pleomorphic lipoma.
Pleomorphic
Perfect.
lipoma. What's good for that?
It has the pleomorphic cells between the fat lobules.
Has a pleo yes. What else does it have?
It also has that ropey collagen.
Ropey collagen. It's amazing how they all have it. I actually so there are some findings that are just there by self-selection because they're just there and they love to test it over and over again, but in real life it's just not there. But so far from what I've seen, like ropey collagen is a pretty fairly reliable finding in these like spindle cell lipoma, pleomorphic lipoma. Anyway, but we'll get to line. We're gonna get to some more interesting, more nefarious elements eventually. But first, what do you think this one?
Angiolipoma.
Angiolipoma. Okay. Where are these commonly located?
Forearm.
Yeah, the extremities, forearms. Painful or painless?
Painful is on the
Painful.
Bengals
Oh.
differentiation or Bengals mnemonic.
Yeah, the Bengals mnemonic. Good. And sometimes you can get the thrombosis, these fibrin thrombi in these vessels gooped up. Whether that's the reason they're painful or not, I'm not sure. But if it helps you remember that if you clog up your vasculature in your lipoma, they start hurting, all the better. Okay. Fat. Yes.
Yeah,
There's fat here.
a lot of that.
Some septae here. A little bit thicker. What happened here? Or here.
Is this multinucleate giant cells? No.
Well, you know, I argue it's multinucleate. I wouldn't call this a giant cell.
They're atypical.
They're very atypical.
Like, is
Yes.
Mm,
it a mitosis?
I don't see it going through mitosis, but it's certainly atypical. It's very hyperchromatic. It's
Yeah.
large. They're very pleomorphic. In fact, look at all of these cells here. They're pleomorphic to each other.
Is this like the well differentiated uh
Yes. Yes, go on. Keep
liposarcoma?
going.
Like well differentiated or atypical liposarcoma?
Yeah, well-differentiated
Like
liposarcoma, or some other another name for that.
Atypical lipomatous tumor.
Lipomatous tumor, yes. Now notice that in the case of pleomorphic lipoma, you kind of have these pleomorphic cells like essentially everywhere. Some say that in these well-differentiated liposarcomas or atypical lipomatous tumors, the atypical cells tend to aggregate toward these thickened septal areas, like here, here. So at least in this case, it actually is kind of reading that. Good. And here's just another example of this septa with a whole bunch of atypical cells that are sort of aggregate to the septa. Also, you start having these, another feature described, you start having these not just pleomorphism of the nuclei, but variability of the fat itself. Okay. What about this?
Another tumor, spindly, or yeah, I guess you say it looks a little spindly.
Yeah. Spindle
This
cell
is,
neoplasm.
I think it
Anything
looks
else?
like muscle,
Muscle, good.
like a pilar
This is
line.
a lot. Yeah.
Ooh, hold on. I heard two people start with two different diagnoses.
I was leaning towards leiomyosarcoma,
And tell me why.
um, because of the smooth muscle, and then sarcoma because they don't look regular. The cells look pretty atypical. Um,
Describe the atypia. What are you seeing?
I'm trying to see if I see I see some mitoses.
Good.
Yeah, those little guys there.
Yeah,
And then
there's
for some reason, like I just associate leiomyosarcoma with this look of like the groups of this is going to sound really just bizarre, but groups of cells going in different directions. See
well,
how I like,
they are going
yeah.
in. Yeah, they're not all going in the same direction. One thing I
No, no,
want you
no.
to,
It
once you
looks
get to
like it looks
muscle,
circular
yeah.
somehow.
Once you get to muscle, I want you to also look at the density. Like how many smooth muscle cells are in like a given unit area. Leiomyosarcoma, what we call, we'll discuss of whether we should even call these cutaneous leiomyosarcomas or a different name. But for all intents and purposes, cutaneous leiomyosarcomas, if that name appears on the exam, will have a higher density of these smooth muscle cells, as opposed to leiomyomas, which for muscle, you won't have this amount of density usually. And yes, you noted the mitotic figures. There is a debate about whether we should call cutaneous leiomyosarcomas, or we should call them, what's the name, atypical dermal smooth muscle neoplasms. There has been a push to, in this case, call them the latter. However, there's a recent pushback to call them, to not make that differentiation anymore based on some longitudinal analyses that recently got published in JAD. Although I am not convinced by that analysis, just for the record. But that's a debate for another time. Anyway. Yes, but exactly right. You notice you notice that something was off about it, but you should notice the cellularity as well, and then you picked up on the mitotic figures. Excellent.
So this would be considered like a superficial, like, because I know like there's some terminology like superficial, dermal, and deep.
So are you talking, well, in this would be, look, they can give you either name technically. They're one of two. They can say this is, on the answer choices, they can say cutaneous leiomyosarcoma. That's an answer they can give you. And that would be the correct answer. Another possible correct answer they can give you, if they want to give you a different name, they can say atypical dermal smooth muscle neoplasm. They can give you that name. Technically, that's the correct name as well. But the point is that it behaves differently than, for example, a uterine leiomyosarcoma. That's
Well, it behaves differently once it gets into the subcutis and
right.
hits the larger vessels. So that's why they're using this. When it's in the dermis, it's just like AFX. If it's entirely within the dermis, it has no metastatic potential. But once it hits the bigger vessels in the subcutis, so that's why there's the pushback on using that term leiomyosarc if it's entirely dermally based, because they don't want people overtreated unnecessarily.
Exactly. Now, you're not responsible for resolving that debate, obviously. They're not going to say who's right. They're not. So what they shouldn't do is they shouldn't give you both of those answer options. That wouldn't be fair. They shouldn't say dermal leiomyosarcoma and also give you an option that's atypical, because that debate is still going on. But you should be aware of both of those names, because they can give you either one.
And those guys have snack packs too, right? And whoever it
Yes.
was that was really good, that you picked up on the fascicle growth pattern. That's probably what you were pointing out, that fascicular growth pattern. There's like swaths of cells going in different directions.
Yes, that you articulated it much better than I did. But yes, visually, it just like they're going in different directions. And I just associate that with
yeah, that's great.
leiomyosarcoma.
What about this one?
Kind of looks similar to the previous.
It's more like collagen trapping here.
Wait,
Yeah.
in what way does it look similar to the previous? Let's go over this.
Kind of looks like spindly as well,
It is spindle, okay.
but it doesn't look nearly as dense.
Not as dense, okay. That's important.
There's collagen trapping, like Nick was saying.
Collagen trapping. Well, what about the differentiation of the cells?
There's the paranuclear vacuole, so it looks like muscle as well.
Yes, good pickup. So you want to attune yourself, because this is going to be different. Like, you don't want to get led down astray with dermatofibroma. Like, oh, look, collagen trapping. But then you see this is muscle differentiation. They have their glycogens back.
Oh, you got me. So this is a power leiomyoma.
The leiomyoma, yeah. Pilar leiomyoma in this case. By the way, there's only a limited amount of muscles that we can get neoplasms from in the skin.
So erector pili.
Okay, erector. So what are all? Let's go through them. So erector pili muscles. Okay, fine. Yes. What else? Where else does smooth muscle exist in the skin?
In the arteries.
In the what?
Vascular smooth muscle.
Yeah, vessels. Vessels have smooth muscle. What else?
In genital area.
Okay, it's more specific.
Smooth muscle or just like
What names? There's names of these smooth muscles. Like if you have a scrotal leiomyoma, where could that come from? What smooth muscle is in the scrotum?
It's been like 10 years since I took anatomy.
They asked this, by the way. So you have to know the dartos muscle. Dartos muscle.
I've never heard that word in my life.
All right,
Dartos muscle.
all right, so we have to go through them because they're gonna give you. They can ask you names. So we have them. Well, by we I mean some of us have a muscle called a dartos muscle. So some of you may have learned that the optimal temperature for sperm production is lower than body temperature. And that's important. And that's why there's in the male gonads are external. And there is a regulatory component. One aspect of that is the dartos muscle. It regulates temperature of the testes by contracting and allowing the scrotum to actually sort of shrink or shrivel up when it's cold. So that's the dartos muscle. You can get leiomyomas from there. Any other areas where we have smooth muscle?
Like near the nipple.
Okay, what are those muscles?
I might be making this up, but areolar.
Okay, they're in the areola. Okay, in fact, now that we're on that topic, what's this, by the way?
Accessory nipple.
Accessory nipple.
Oh,
And
yeah,
you
that's all right.
notice, by the way, how some of these smooth muscles are coming into your screen, almost like they're wrapping around this structure. And some other muscles are arranged radially outward. The muscles that are going around concentrically, so you have two types of muscles in the nipple. There are circular, circumferentially arranged smooth muscles. Those are
Oh, like
called the muscles.
sphincter muscles or
Those are called the muscles of Sappi. Those are the ones that are circular, around, going around the areola. They contract. They assist in milk expulsion and lactation. And then there are the muscles of Meyerholz, which are the radially arranged muscles outward. Those are responsible for, well, some of you may have gotten cold and the areola size has shrunken and then the nipple has extended outward. That's what this muscle does. Muscle of Meyerholz. You can also get leiomyomas from that muscle. So you can get leiomyomas from your rector pili muscle. You can get leiomyomas from your smooth muscle blood vessels. You can get the dartos muscle leiomyomas, as in the case of scrotal leiomyomas. You can get leiomyomas from the muscle of Sappi or the muscle of Meyerholz. Any of them. Very good. One more little practice.
Leiomyoma.
And why you say leiomyoma?
Well, I'm looking for like atypia and like mitosis, which I don't really see differentiate between that and
You don't see any?
what I don't know. Like they're moving pretty fast, so it's
Oh,
kind
sorry. Sure. It might be a lag.
of okay. So they look a little bit atypical. There aren't as many noticeable mitosis in this example than in the previous one, but the nuclei look um sort of like atypical.
This.
That's nice mitosis.
Okay. Why, by the way, why is it such a sensitive thing, mitoses in these muscles? Like, why is one mitoses? All of a sudden, people get so concerned.
I mean, smooth muscle doesn't really proliferate.
Yeah, muscle cells typically don't. Yeah, it doesn't. Typically doesn't do that. Anyway, and yeah, this again, like let's compare the density. If we talk about density, remember this example? And remember, it was so little dense. It was less dense. You actually noticed collagen trapping. We were going to go down the dermatofibroma route. Not so in this case. Well, actually, maybe you will go down the dermatofibroma route. But anyway, good. You know, okay, so sometimes they can be more subtle. But in any case, I actually do think there are a decent amount of atypical cells here. And if you look hard enough, you can actually find more mitotic figures. Here they are as well.
So, Avi, just for you too, it's not uncommon to find, a fair amount of atypia and just benign leiomyomas from time to time. And then, but yeah, like mitoses are usually, those are more unusual. And then, yeah, the collagen trapping, as you guys know, it's not specific to DFs. Like you can see it at the edge of KS, at the edge of THH. In this, like this is a good clue, leiomyomas tend to ramify between collagen bundles where leiomyosarc tends to replace it. But anyway, some thoughts.
What about this one, guys?
This is full of fat, but it looks
Yep,
very pleomorphic.
definitely pleomorphic.
This fat is almost like saponifying, would you call that?
Well, I mean, I can see why you're saying that. I don't see true saponification, though.
Okay.
I mean, I do see this looks nasty. I mean, this looks like these are very immature adipocytes, which we call, by the way,
Lipoblasts.
lipoblasts. And they're
Pleomorphic.
everywhere.
There's a lot of good degree of pleomorphism. There's atypia.
Yep.
I'm sure you can find some mitosis of pleomorphic liposarc.
Pleomorphic liposarc. That's good. Perfect. This is pleomorphic liposarc. You see this amount. Very loaded with immature pleomorphic lipoblasts. What happened here?
This bone formation.
That's bone. Why'd that happen? So, I mean, you have a diagnosis right now. You basically just said the diagnosis.
Osteomycutis.
Osteomycutis. Very good. Any thoughts on why the patient has osteomycutis?
It can be like idiopathic, like from acne, I think.
Okay.
Um,
Hey, listen, what do you think is going on here?
it looks like it's part of a
It's
follicle.
in a follicle, right? So, is that like a coincidence? It's in a
No.
follicle?
Well, it could be, but probably not.
Probably not. I mean, so what happens to patients who have osteomycutis from acne? Like, what do they look like? How do they present?
Except like papules on the face.
Yeah, they've got a bunch of osteomycutis all over their face. Wherever these follicles were, wherever these acne lesions were, it's like it just has bone in it. You guys know how to treat it?
Excision
Yeah,
or
actually.
diltiazem, I guess.
Yeah, well, no. You're absolutely right. So you can put the patient on acne medicines and everything, but that's not going to get rid of the bone. Once the bone is there, the bone is there. So you actually have to go take your you numb the area up, take an 11 blade, and just cut each one out. And that's the only way to get rid of them. Once you get osteomycutis from acne, you just are going to just spend a lot of time each one. However, you have a very grateful patient at the end of it. But it's quite the procedure. Okay. Some sort of thing Now we're not making out a whole lot here, but what are we making?
We had a lot of nuclei. There's this, I guess, a vessel. It looks like a vessel.
Yeah, it is a vessel. I mean, we see blood in it, right?
Is this KS?
Well, in KS, so it's not KS. In KS, that we don't really have vessels that are this well formed,
Oh, yeah.
and also we would look for other things. We would look for things like well, it depends what stage we're in, but things that go against that are the well formed nature of the vessels. Depending on which stage we're looking for, we would look for promontory signs, which I'm not seeing here. Also, if it's more of a nodular form, it's usually more dense, and I would look for, what's
Like slit-like spaces with erythrocytes within them.
exactly dwarf ball, some people call them.
Well, you'd have actual erythrocytes, like red blood cells within slit-like spaces for nodular KS. So that would be one thing, and it'd be more densely packed than this, more blue than that pale.
Yeah, this is kind of loose. But we did have something that we were looking at. We did see some sort of arbor. What is this vessel patterning in? How would you describe these vessels?
You just kind of gave away arborizing.
Yeah, arborizers. Some people call them chicken wire vessels. And I'm going to give you, so you can't fully get the answer on this, but I'm going to give you an immuno. Okay, first of all, tell me if it's positive or negative.
Positive.
All right, the immuno is MDM. Does that ring any?
Okay.
MDM is like
MDM2, MDM2.
liposarcoma.
Yeah. So that was a dedifferentiated liposarcoma, but they do stain positive for MDM2. So that's something they like to test, by the way. You have to know MDM2 with liposarcomas.
So how would you know to order it in this case? Because there's not like obvious like lipo.
There was one feature. So okay, that's a good point. So one thing you can sometimes, if you look at the edge, although I have to say not so obviously in this case, if you look at the edge, sometimes you could see more well-differentiated portions of liposarcomas. This example, though, I was very mean. So I picked one where you don't really have that when you go to the edge. So, I was just not nice. But the one thing actually that we did show is, and this is not specific, but should at least make one think about something, is the chicken wire vessels. Those are described as well. But yeah, in practice, though, sometimes you can look at the edge and you can see areas that have more differentiation instead of just working with a completely undifferentiated specimen. Now, this one they definitely can test.
Hibernoma.
Hibernoma, yeah.
Okay, and what's the function of this type of
It's like
cell?
brown fat.
It's brown fat, isn't it,
Yep,
to keep you warm?
keep you warm. Thermoregulation. And this?
Accessory tragus.
Accessory tragus, good. You guys know that. We already went over
Great. What branchial arch is it again? Two?
Second?
First.
Ooh.
Oh.
There you go,
Ooh.
first.
It's either one,
By
two,
the
or
way,
three.
I think
by the way,
brachial cleft is second.
it's the by the way, do you guys know the wattle? Which one that is?
Excuse me?
No.
Wattle?
Mm.
Congenital breasts. They're related to accessory trachea. Well,
You lost me at Waddle.
okay. First and second branchial arches, and then a wattle. A wattle is they're on the neck They're kind of like cartilaginous, congenital cartilaginous rests. Does that ring it? Congenital cartilaginous rests of the neck?
The
Mm,
externocleidomastoid
No.
area.
mm,
Yeah.
no.
Well, anyway, they're thought to all occur. They're not exactly the same thing, but they're sort of related. Some, but that's why you can get cartilage. It's a wattle, a congenital cartilaginous rest of the neck. It's another anomaly during embryogenesis. But I think a wattle is the sixth. Let's see. I'm right about that. First and oh no, also first and second branchial arch, auricular. So they are related. What about this one?
Looks like it's on the hand.
Okay, a little more specific. Where on the
Is
hand
that
are we?
nail? Is that nail
Yeah.
right there?
Uh-huh.
Exostosis.
Yeah, subungual exostosis. Perfect.
Mm.
Subungual what, Nick?
Subungual exostosis.
Oh,
Exostosis.
exostosis.
It's like where the bone goes through the
Got a
like
bone under your nail. This is nice. You got all the components. By the way, when we get osteoma cutis of just about any sort, usually when the bone is forming of previous fibrous material, does the bone form from intramembranous ossification or endochondral ossification?
Intramembranous.
Good. Nailed it. Wow. I'm impressed.
It was a 50-50 shot.
Oh, come on. You got to see when you get it, when you nail it that good, you got to walk away with it. You got to be like, come on. All right.
I don't like how this looks. A lot of collagen. Mm.
There are clefts between, like an abnormal amount of clefting between the collagen, I think.
There are some clefting. I'm not sure I'm not sure what the significance of that clefting
Okay.
is. There's something you can see like right here. I mean, if they're coming at you in the z-axis. Well, we
I
have
don't
cells
know
here.
what you're pointing to. Are
So we
these
have a
smooth
group of
muscle
cells.
bundles? No, these are not smooth muscle
Yes.
bundles. Oh, okay.
Yes.
Great. Smooth muscle bundles.
Smooth muscle. You see the vacuoles, right?
Yeah.
Hmm.
And by the way, we look at the site. What's all these?
Also smooth muscle
Also
bundles?
smooth muscle
Yeah.
bundles.
Is this like a hamartoma?
Well, are they okay? So hamartoma is normal,
Yeah.
not abnormal, and it's just the
This is
replication.
abnormal?
Well,
Yeah, I would
this
say this
is
is
normal. This
abnormal.
areas are normal. This is just the site.
Right.
Is this on the
That's the point. Do you see how this smooth muscle is not the same as like this giant thing of smooth muscle?
Yeah.
Yeah.
Like here's normal smooth muscle.
is this on the breast?
Well, let's figure it out. Though it could be
I don't
hard to
see a
figure.
lot of ducts.
There aren't any. And they'll just say by the well, I guess you could have that in this case, but this is a scrotum.
This is another angiosarc.
Angiosarc? Why are we saying angiosarc?
Not angio. um, Leiomyosarcoma.
Why are we saying leiomyosarcoma? Did we see mitotic figures?
Not
Not that
really,
dense.
though.
There's 8, so there's some pleomorphism, but that's
Yeah.
what we just said. Shane just pointed out you can have some pleomorphism in leiomyomas.
Genital pilar myeloma. I don't know.
Well, that's
Pleomorphic
okay. So genital
dermal
pilar is a
sarcoma.
possibility, but what's also a possibility that they will love to test you on this side. We just went over this, guys. What muscles can we get?
Oh, the dartus muscle.
Dartis
Dardos
muscle.
muscle. So they can show you an example just like this, and they can say the muscle of origin that this neoplasm originated from was involved in what of the following? And one answer is thermoregulation, and that'll be the answer. That's an example of how they love to ask it. Just like that. So like a third order question.
A leiomyoma, not leiomyosarcoma.
This is a leiomyoma. There's atypia, no mitotic figures. Density is not that crazy. It's also fairly well circumscribed, by the way. Didn't do the circle that well, but you can see how that's fairly well circumscribed. So yes, dardos muscle, scrotal leiomyoma. All right. Now that we're on the topic of circumscription, what do you guys think?
Well circumscribed.
Well circumscribed. I agree.
It almost looks like it's like bone or like
Or cartilage or something.
cartilage, yeah.
Which one?
Cartilage?
Cartilage. Yes.
A chondroma?
Perfect. This is a chondroma. End of story. Unlike this, which is a
Chondrosarcoma?
yes. You notice the same differentiation. You notice it's. What do you guys think about this circumscription?
Not great.
Terrible. Absolutely horrible.
It just looks more nasty too.
I agree. I think it looks nasty. I mean, but yes, I know where you're getting. Okay. Here's one thing that they may start asking. Actually, not may, but anyway. All right, so let's take a look at this. So we have this neoplasm.
Mm-hmm.
And let's try to just characterize it. Let's try to describe it. So what do you guys see?
I see collagen in the background, but then these um
Yep, there's collagen in the background.
yeah, these like we guess they call it like vacuolated or like
Yeah, there's clear spaces.
yeah.
Clear cells.
Clear cells. There's also some areas where there's some granular areas also.
Mm-hmm.
Clear, granular. And yes, you noticed the sort of architecture. There's some structures that are still here.
Mm-hmm.
Bundles of collagen are still here. This erector pili muscle. By the way, does everyone recognize that this is smooth muscle?
Mm-hmm.
Mhm.
Erector pili muscle is still here. This hair follicle is still here. Well, that's a
Mm-hmm.
little weird. Sometimes neoplasms just completely like get rid of that.
Obliterate that, but it's still there.
Yeah, weird. Okay, so what's our differential when we see something? And by the way, what do we not have? We don't have a.
We don't have like reedy ridges or a papillary
Well, we
dermis
do
or
have a little bit of that, but we don't have the tumor in the epidermis.
yeah,
Right?
it's respecting the
There's no in
epidermis.
situ component. So that's important. So what's our differential? What are we thinking?
Well, there's like balloon cell nevus or
Okay.
clear cell. Not written. I mean, not. I wouldn't think this is to be like a metastasis of a renal clear cell
That's
carcinoma.
absolutely on the differential. You have to think about clear renal. I agree it may not be that. And what are we missing for that, by the way?
Hemorrhage.
Yeah, a lot of
You're
hemorrhage.
missing the hemorrhage. Also, it's kind of weird that some of the architecture is still present. But okay, yes. So okay, but on the differential, what else is on the differential?
The clear cell acanthoma would involve the epidermis,
Yes,
so
that would be
I do
just
not have that on the
it
differential.
would really just be the epidermis.
Yeah.
This is just the dermis. In fact, it's like the whole dermis. So what else is clear? So we mentioned clear renal cell sarcoma.
Hmm.
Any other clear cell entities? Well, is there a sarcoma that's clear?
Yeah, clear cell sarcoma
A
or
clear cell sarcoma
sarcoma.
also on the differential.
Yeah.
Okay. Is any other cells that are any other clear cell entities?
Said balloon cell nevus.
Okay, balloons. We said that.
Maybe sebaceous.
Sebaceous, but the thing with sebaceous is that we don't really see a whole lot of crenation of the nuclei here.
Mm-hmm.
But okay, we can go with those immunocytes. Another entity, especially when you see those areas of clear and granular, the granularies are pointing out, also that have this architecture, some of this architectural preservation of the collagen. Picomas.
Oh,
Anyone hear of
PCOMAs.
picomas?
Yeah, that's becoming a thing now.
It is becoming a thing now. That's why I'm letting you know about it. Because when you know what happens when things start becoming things?
People want you, expect you to know about it.
Yeah, where do they think you think they want you to expect you to know about it?
On the board or on the chorus.
All right. So perivascular epithelioid cell tube. Okay, so what stains are we going to do? We have to resolve this.
Perivascular, so well,
Wait, how do they stain? How does each one stain?
well, clear cell it stains with PAX8. Um,
Clear. What is clear? You're saying clear cell sarcoma?
clear renal cell sarcoma.
Oh, renal cell sarcoma. Okay, fine.
Yeah.
How's our clear cell sarcoma going to stain?
I think a PCOMA stain for both muscle cells and then melanocytes, I believe.
Okay, the picomas, yes. Picomas will stain for your muscle cells and also some melanocytic markers. We'll get to that. What about clear cell sarcomas? How do they stain? How many of the melanocytic markers did they stain for?
S100.
Yes. And?
Melanie.
Yes. And?
MIT-F.
And what?
MIT-F. MITF.
My
Oh,
TF.
nice, yeah.
So Mart1, Melanae, you can think of those as whether you are of the view that those are two really different stains or the same stain of a different epitope, whatever. Okay, the answer is yes. Anything else? HMB 45? Sox 10? Yes and yes.
So all of them.
All of them. However, there is an exception, though, that is a new exception you need to know about because there's a new hot little stain that you need to know about, which is PRAME. So the one thing that clear cell sarcomas theoretically shouldn't stain for is PRAME. However, unfortunately, there are some melanomas that don't stain for PRAME. So you might have to do more investigation. There are certain genetic studies you can do, but clear cell sarcomas stain for SOX10, stain for S100, stain for Melanae. Are they stain for SOX10?
Yeah, and like Avi said, they've got a different translocation. That you won't find in melanoma. You guys know that, right? So you got to know that translocation. I think it's 1122 or something.
They test this, by the way.
The 1122 is the clear cell sarcoma.
Correct. You just double check that because I haven't read about that in a while.
see
It's
1222.
1222.
12,
There you go.
1222.
All right.
It's EWSR1. Yeah, EWSR1 ATF1 for clear cell sarcoma.
So yeah, it's a really interesting tumor because it looks just like a melanoma. It has melanin stains like melanocytes, but it's got those different genetic markers.
And then picomas You actually can differentiate picomas from clear cell sarcomas with your staining. So what do we have any idea on that?
I think Picoma doesn't stain S100, I think.
Almost. Picomas weakly stain S100. Some people have done investigations where they do PASDs, where they do the diastase and they get rid of some of the glycogen, and then the S100 goes away, and they're like, well, it's just non-specific for things that are in the glycogen. But they can weakly stain S100. What do picomas stain even less for? They'll stain for melanae. They'll stain for HMB45. Oftentimes, SOX10 is dead negative in picomas. SOX10. And what do they stain positive for? Aside from the melanocytic markers? I think someone already said this. Picoma stain, melanocytic, and muscle. So smooth muscle actin and desmin. So again, they do ask this. Clear cell sarcomas. They're going to light up for all the melanocytic markers except theoretically for PRAME. They're going to either involve T1222, either EWSR1 ATF1, or less frequently, EWSR1 CREB1. Picomas will stain for your melanocytic markers HMB45, MART1 melanae. S100 vaguely, focally, weakly, SOX10 dead negative. And also, there may be a question of the tumors to think about when you get keratin negative tumors, S100 positive tumors, vimetin positive tumors. Any of those clear cell sarcoma could be on the differential for that. They can also, and by the way, just like they can ask something that's benign, they can just give you the same immunostains and give you something like this. So let's say they gave you something. First of all, let's just take a look at this. How do we think this looks?
Not great.
Not great. Now let's look at the cells. How do you think it looks?
Also not great.
Also not great.
Pleomorphic.
Now I give you the stains. And I say it's positive for melanae. It's positive for HMB45. It's dead negative for SOX10. Positive for desmin, positive for smooth muscle actin. And only very weakly positive for S100.
Picoma.
Picoma is the diagnosis? What's wrong with picoma? Matches the staining perfectly, I agree. What's wrong with it?
It's like, this is more nasty.
Yeah. So what do we call a malignant picoma?
He
Just that.
Ecosarcoma?
yeah,
A malignant
picosarcoma.
picoma.
Oh.
That's the
Malignant
name.
picoma. Okay.
This is a malignant picoma. So this is a picoma, and this is a malignant picoma. Actually, we'll start with this one before we go to that one, because I think you guys know this one. Blue hue.
Is this a neurothecoma? No, I thought I knew it, but I take it back.
Well, what do we see?
It's like, yeah, the blue hue,
Blue hue, myofibroblast, and the vessels are, you can go to the periphery and you see this proliferation of vessels. According to some, there are hemangioparasitic-like vessels, even not at the periphery. Very well circumscribed.
yeah.
So
I think you give away the name. I think it's infantile hemangiopericytoma, or
no, I didn't give away the name, and that's not what it is.
oh, I see.
And I don't think they're going to ask you about that, Anthony, by the way. But if you want, we can do a bonus session. We can go over it. Well, this is more simple. Think a little less. Look, what's at least give me a differential. What are you guys thinking? You're in this. I know you're in the category. So we see what things have this bluish hue that have these myofibroblasts, vessels.
Mm.
Is this a cutaneous myoepithelioma?
Cutaneous myo,
Epithelioma.
not cutaneous
No.
myo. Oh, we're getting so close.
Myofibroma.
Yes, it's a myofibroma. It's solitary nodular tumor, well circumscribed. You can
Is
see it's
it
benign.
biphasic?
Yes, they have been described to have biphasic components. Some hyalinized areas, and then this bluish hue areas.
Yeah, they're usually biphasic. It's usually those less cellular bluish areas and then the
Mm-hmm.
more cellular, less blue areas. And those can vary with they can be at the periphery of those bluish nodules and small, or they can be large and in the center like this one.
Then what about this one? And then you'll notice that we have some of that blue that's still there, right?
Yeah.
Yeah.
Myofibrosarcoma.
Oh, don't jump the gun on that. What do you think about the circumscription?
It's well circumscribed here too.
I don't see raging mitotic figures or even pleomorphism.
Yeah, it looks more crowded.
I do see a few things though. That's a little bit different. So I see these vessels and I see some areas where it's almost kind of whirling,
Hmm.
like a concentric pattern of some of these. And
Hmm.
some people think these are like on a spectrum and they're not distinct. Some people think they're distinct entities. But if there's a parasitic component, myo, have you heard of myo?
Pericytoma.
Have you heard of myoparasitoma?
Just now.
Nope.
All right. Well, they're probably, I mean, just in case they ask that. I don't think they will ask that, but the things I really stressed that do really hit on. Do read up, like know your PCOMA, know your clear cell sarcoma, know all of the, you know those named muscles, know the named muscles of the that you can get leiomyomas from. Anything that they can ask those third order questions on, they love those. They eat those up.
It's the
Hibernomas.
dartos muscle and the erectile muscle, right? That's what we said.
The dartos. Wait. Dar dartos muscle, yes. And where is that?
Scrotum and
Scrotum.
labia.
Scrotum. Okay. And then what are muscles of the nipple? Sappi and Mayerholtz.
Erectile.
Sappi is the concentric one. Mayerholtz is the radial one. What other sources? Blood vessels, erector pili muscle. Any of those, you can get it. What gene is what stain is good and helpful for like a differentiated liposarcoma or liposarcomas more broadly? So
Oh,
liposarcoma,
MDM2.
MDM2, yes. They test it all. They love it. All right. But you guys know it. You're gonna kill it. Okay.
Are we on Thursday doing that like big board review?
Yes. Thursday,
Okay.
I'm gonna be with you guys for hours. And
And we're doing like all the high yield stuff, not the
we're gonna
crazy
do
stuff.
lots of high yield stuff. Yes.
Okay.
Back to back
Thank God.
hours of
I
high
need
yield
a I
stuff.
need a little like morale booster after these
Seriously.
sessions.
Okay.
Seriously.
I hereby bestow upon all of you morale boost.
Thank you, Avi.
Got it.
Thank you, Avi.
Okay,
We'll
we'll
see you
see you
on Thursday,
Thursday.
and it's gonna be hours of the Dermpath, okay?
I'm so ready.
So stoked.
All right.
Bye.
Have a good night, everyone.
Hey,
Good job,
Avi.
Avi.